Welcome to Nephrology Notebook. Today we're looking at SONAR, a trial that asked a practical question. Can Endothelin-A blockade reduce kidney events in diabetic kidney disease without recreating the fluid retention problems that limited earlier endothelin drugs? The answer depends on one key idea: carefully selecting patients by their early physiologic response. The headline is not simply that Atrasentan lowers proteinuria. SONAR tested whether a short, open-label trial of therapy could identify patients with meaningful albuminuria reduction and minimal fluid retention signals. In that enriched responder group, Atrasentan reduced major kidney outcomes. So the teaching point is precision-nephrology. Response first, long-term exposure second. To anchor the trial, meet Marcus, a 65-year-old man with long-standing type 2 diabetes, hypertension, preserved cardiac stability, and severe albuminuria despite kidney protective therapy. His estimated GFR is in the low 40s, and his urine albumin to creatinine ratio, or UACR, is 950 milligrams per gram. That red flag is exactly the residual risk phenotype SONAR was built around. Marcus is already doing many things right: renin-angiotensin-aldosterone system blockade, an SGLT2 inhibitor, blood pressure control, and diabetes management. Yet albuminuria remains high. This is the clinical ceiling. Even optimized foundational therapy does not eliminate residual kidney risk. SONAR explored whether a targeted add-on pathway could reduce risk in selected patients, not in everyone. Albuminuria is not just a lab abnormality. In diabetic kidney disease, persistent macroalbuminuria marks ongoing glomerular injury and strongly predicts kidney failure and cardiovascular risk. SONAR used albuminuria in two ways: as a risk marker at baseline and as a response marker after Atrasentan exposure. That makes proteinuria both the warning signal and the filter. Diabetic kidney disease sits at the intersection of kidney failure, cardiovascular death, and major health system cost. Many patients die from cardiovascular disease before reaching dialysis, while those who progress to kidney failure face high morbidity and resource use. This global burden is why even incremental risk reduction in high-risk albuminuric CKD can matter clinically. SONAR targeted endothelin-A, a potent vasoactive and pro-fibrotic pathway. In the diabetic kidney, metabolic stress, oxidative injury, and endothelial dysfunction can amplify endothelin signaling. Endothelin-A promotes vasoconstriction, inflammation, fibrosis, and podocyte injury. The concept is that residual albuminuric risk may persist through pathways not fully addressed by RAAS blockade alone. The endothelin pathway was attractive because earlier agents lowered albuminuria. The problem was toxicity. Less selective endothelin blockade increased sodium retention, edema, and heart failure, undermining the kidney signal. SONAR's innovation was not just a different drug. It was a different trial architecture, designed to separate likely benefit from early volume risk signals. Endothelin biology is receptor-specific. ETA activation tends to drive vasoconstriction, proliferation, inflammation, and fibrosis. ETB activity is more protective: nitric oxide release, sodium excretion, and endothelin clearance. So the pharmacologic goal is selective ETA inhibition while preserving ETB function. That receptor selectivity is the rationale for Atrasentan. Atrasentan is a selective endothelin-A receptor antagonist. Mechanistically, it aims to blunt the injurious ETA pathway without fully blocking ETB-mediated sodium handling and vasodilation. That distinction matters because the clinical challenge is not whether albuminuria can fall. It can. The question is whether the patient can tolerate the drug safely over time. Think of Atrasentan as a balance. On one side, potential kidney benefit: lower intraglomerular stress, improved endothelial barrier function, and lower UACR. On the other side, the class effect: sodium and fluid retention, BNP rise, hemodilution, and anemia. SONAR tested whether early monitoring could identify who lands on the safer side of that balance. The hypothesis was elegant. Before committing patients to years of therapy, give Atrasentan briefly and observe the physiology. Does albuminuria fall? Does weight rise? Does BNP increase? This test drive became the enrichment phase. It was meant to maximize the chance of kidney benefit while reducing exposure in patients showing early volume intolerance. SONAR began with screening and optimization of RAAS blockade and diuretics. Then came 6 weeks of open-label Atrasentan at 0.75 milligrams daily. Only patients with the desired albuminuria response and no major fluid retention signal entered the main randomized phase. The design itself is the lesson. Trial architecture can shape both efficacy and safety. The trial deliberately enrolled high kidney risk but cardiac stable patients. Type 2 diabetes, eGFR 25 to 75, UACR 300 to 5,000, and maximally tolerated ACE inhibitor or ARB therapy. It excluded prior heart failure, severe edema, high BNP, and non-diabetic kidney disease. So SONAR is not a broad DKD trial. It is a selected risk trial. To enter randomization, patients had to pass the Goldilocks test, enough efficacy without too much volume signal. That meant at least a 30% UACR reduction, no major weight and BNP fluid retention signal, and no significant creatinine rise. In practice, the trial asked the patient's physiology for permission before committing to long-term therapy. Even after strict filtering, the randomized population remained high risk. Mean age was about 65. Mean eGFR was roughly 44, and median UACR was about 803 mg per gram. Nearly everyone was on ACE inhibitor, or ARB therapy. This was not mild diabetic kidney disease. It was persistent macroalbuminuria despite optimized baseline care for that era. Responders were randomized to continue Atrasentan 0.75 mg daily or switch to placebo, both on top of standard care. Median follow-up was 2.2 years. The key point is that the trial was event-driven and focused on clinical outcomes: kidney failure, sustained creatinine doubling, and death from kidney failure, not just short-term albuminuria changes. The primary endpoint was a kidney-dominant composite: sustained doubling of serum creatinine, end-stage kidney disease, or death from kidney failure. Secondary endpoints included 50% eGFR decline and a broader cardiorenal composite. This matters because albuminuria was used for enrichment, but the main question was whether that enrichment translated into harder kidney outcomes. Here is the efficacy signal. In responders, the primary kidney composite occurred in 6.0% with Atrasentan versus 7.9% with placebo, a hazard ratio of 0.65. That is a 35% relative risk reduction, the safest interpretation. In carefully selected responders, Atrasentan reduced major kidney events over a median 2.2 years. The kidney signal was supported by secondary outcomes. Atrasentan reduced the risk of 50% eGFR decline, improved the cardiorenal composite, and slowed annual eGFR loss from about 3.1 to 2.4 milliliters per minute per 1.73 square meters per year. These are modest absolute differences, but meaningful in a high-risk albuminuric population. The enrichment design appeared clinically important. Responders showed clear separation between Atrasentan and placebo. Non-responders had a trend in the same direction, but it was not statistically significant and the subgroup was not powered for certainty. The takeaway is not, non-responders never benefit. It is that SONAR's strongest evidence applies to the responder phenotype. The safety signal did not disappear. Even after screening, fluid retention and anemia were more common with Atrasentan, and heart failure hospitalization numerically increased, though not statistically significant. That is the clinical trade-off. ETA blockade can reduce albuminuria and kidney outcomes, but it demands volume surveillance, hemoglobin monitoring, and careful patient selection. SONAR is as much a trial design story as a drug story. It used enrichment in diabetic kidney disease, focused on hard kidney endpoints, and enrolled patients across 41 countries. The design revived interest in Endothelin-A blockade by showing that early response and tolerability can be used to enrich for benefit. Two caveats are essential. First, the trial stopped early because event rates were lower than expected, which limits certainty despite a statistically significant primary endpoint. Second, generalizability is narrow. These results best apply to patients who pass the 6-week physiologic stress test, albuminuria response without early fluid retention, or creatinine safety signals. Conceptually, ETA blockade fits above foundational therapy, not instead of it. Modern care still starts with optimized RAS inhibition, SGLT2 inhibitors when appropriate, and non-steroidal MRAs such as finerenone for selected patients. Atrasentan should be framed carefully. SONAR supports biologic plausibility and selected patient efficacy, but diabetic CKD use remains specialist-guided and not a routine U.S. indication. Returning to Marcus, he resembles the SONAR responder screening phenotype: high albuminuria, maximized RES blockade, stable heart status, and low BNP. But that does not mean automatic treatment. The practical decision is specialist discussion, trial or off-label context where appropriate, and if used, close monitoring of weight, BNP, edema, creatinine, potassium, and hemoglobin. SONAR points toward a broader nephrology principle: test to treat. If ETA blockade is being considered in an appropriate specialist context, the early check is central. At about 6 weeks, reassess UACR, weight, BNP, and kidney function. If albuminuria falls and volume status is stable, continuation becomes more rational. If fluid retention appears, stop. 3 pearls to close the teaching. First, ETA signaling contributes to vasoconstriction, fibrosis, podocyte injury, and albuminuria. Second, Endothelin blockade carries a class effect risk of sodium and fluid retention, so unmonitored use is unsafe. Third, enrichment design helps identify patients most likely to benefit and least likely to show early volume toxicity. The final message for Nephrology Notebook is this: SONAR is not a license to treat every patient with diabetic kidney disease. It is a model for precision nephrology. Listen to the early physiologic response, then decide. For more kidney trial breakdowns and practical nephrology teaching, subscribe to Nephrology Notebook and share this with a learner or colleague.